Okay, good evening, everyone. Am I audible?
Yes, sir, you are audible. Please make it full screen, sir.
Okay, how can I make this screen on the full view?
Sir, at the top, there is the option slideshow.
Okay, now, yeah, it has done.
Yes.
Okay, so thank you, Dr. Praveen, for the wonderful presentation on the recent advancement in HER2 positive metastatic breast cancers. Now, I am going to discuss about the recent development in the management of HR positive and HER2 negative metastatic breast cancer patients. This is the temporal profile of development of hormonal therapy in metastatic breast cancer patients. The first hormonal therapy, that is the tamoxifen, which is ACRM group drugs, it was introduced in 1977. And if you see from 77, there is 2 decades happens to the development of next line of therapy, that is the aromatase inhibitor. And the 3 aromatase inhibitor, that is anastrozole, letrozole, and exemestane, that invented side by side within a period of 2 years. First time in 2002, the first injectable fulvestrant, that is hormone therapy, injectable hormone therapy was developed. And after then, again, there was a gap of around 1 decade till the 2015, when there was the first CDK4/6 inhibitor, that palbociclib, was introduced. It was approved for the treatment of HR positive, HER2 negative breast cancer patients as a first line therapy, along with the aromatase inhibitor. After 2015, in 2017 and 18, another CDK4/6 inhibitor, that is ribociclib and abemaciclib, was also approved for the same indication. The indication of palbociclib, in case of female, the palbociclib is indicated for the treatment of HR positive, HER2 negative, locally advanced and metastatic breast cancer patients, either in combination with aromatase inhibitor or in combination with fulvestrant in those women who have received prior endocrine therapy. In pre or perimenopausal females, the endocrine therapy should be combined with the LHRH agonist. In case of male, the palbociclib is indicated for the treatment of HR positive, HER2 negative advanced breast cancers, along with the aromatase inhibitor as initial endocrine therapy, and along with the fulvestrant in those patients who have received prior endocrine therapy. So now, what are the data says when this CDK4/6 inhibitor are used as a first line or as a subsequent line? So when CDK4/6 inhibitor is used at the first, there are 4 important trials has been done: the Paloma 2, Monarch 3, and Mona Lisa 2 for in the postmenopausal females, and Mona Lisa 7 for the pre and perimenopausal females. And if you see the median PFS in all 4 trials is almost similar. It varies from 25 months to 28 months, with the hazard ratios also almost equals 0.5 in all these 4 trials. The overall survival data is not matured in 3 trials except this Mona Lisa 7, where the overall survival data matured and say that the overall survival is around 60 months versus 48 months ribociclib versus placebo. Now, the main focus, the palbociclib, when it is used as a the first line therapy, what the global phase 3 trial says. The Paloma 2 trial, it was the phase 3 multicentric study. It was the inclusion criteria was the patients included postmenopausal females, ER positive, HER2 negative breast cancer patients. No prior systemic treatment for the advanced disease has been taken. Those patients who have taken adjuvant chemotherapy and hormone therapy as an adjuvant setting, and in whom the disease-free interval were more than 12 months, were included in the study. The randomization was done 2:1. In palbociclib arm, the dose was 125 milligram once daily plus letrozole, and in the second arm there was the placebo plus letrozole. The primary endpoint of this study was the investigator assessed PFS, and secondary endpoint was the pharmacokinetics, safety profile, and patient reported outcome. On the median follow-up of 37 months, in palbociclib arm, the median PFS was around 28 months, versus in placebo arm, the median PFS was around 15 months. So the median PFS is almost double in case of palbociclib plus letrozole arm in compared to the placebo arm. On subgroup analysis, if you see this, the forest plot, the benefit is seen across all subgroup of patient, irrespective of age, irrespective of whether the disease is visceral mets or non-visceral mets, or is there only bony mets, whether the treatment-free interval was less than 12 months or more than 12 months or more than 2 years or 5 years. The benefit was seen in across all subgroup of patients in the favor of palbociclib plus letrozole arm. So the conclusion of this PALOMA-2 trial, so after 37 months of median follow-up, the palbociclib plus letrozole consistently saw improvement in median PFS versus the placebo plus letrozole in the overall population, that is 27.6 versus 14.5 months, and across all the subgroup of patients. The palbociclib was well tolerated, with most common adverse effects being neutropenia and leukopenia. However, the overall incidence of this neutropenic fever was very low, it was 2%. And even with the long-term follow-up, the safety profile remained consistent with the previous observation, and no new safety signals were observed with the palbociclib plus letrozole combination. The palbociclib plus letrozole, so it should be regarded as an important first-line treatment option in HR-positive, HER2-negative advanced breast cancer patients. Now, what data says when we are using this CDK4/6 inhibitor in the second line? Again, there was multiple trials for this palbociclib, ribociclib, and abemaciclib. The PALOMA-3 trial for palbociclib, Monarch-2 for this abemaciclib, and MONALEESA-3 for ribociclib. The median PFS in these trials, in PALOMA-3 trials, the median PFS was around 11 months versus 4.6 months. So the median PFS, when we are using palbociclib as a second line, the median PFS is almost double if you compared with the placebo arm. In Monarch-2 trials, the median PFS is around 17 months versus 9.3 months, whereas in MONALEESA-3 trials, the median PFS is 20.6 months versus 12.8 months. The overall survival data shows in PALOMA-3 trials, it was around 35 months versus 28 months. In Monarch-3, it is much better, the 47 months versus 37 months. And in MONALEESA-3, still the overall survival data has not reached versus the 40 months. But the one thing which is important to see in these 3 trials, that in Monarch-2 trial and MONALEESA-3 trials, they have used only those patients who have not taken any prior chemotherapy, and they have used only one line of prior endocrine therapy. Whereas in PALOMA-3 trials, the patients which are included in the study, they have taken many number of prior endocrine therapy, and they've also taken prior chemotherapy. So definitely the patient performance status were not as good as if you compared with the patients which are included in Monarch-3 and MONALEESA-3 trial. Now, palbociclib data in second lines. The trial was the PALOMA-3. Again, it was a phase 3 double-blind multicentric study. Randomization was done is 2:1. And patients included in this trial were both premenopausal, perimenopausal, as well as the postmenopausal. Those patients who progress on prior endocrine therapy, and those patients who have also taken prior at least one chemotherapy are included in the study. The palbociclib given was again 125 milligram once daily plus fulvestrant, and in second arm the placebo plus fulvestrant. The primary endpoint of the study was the PFS, and secondary endpoint was overall response rate, overall survival, duration of response, as well as the safety and tolerability. This is the updated overall survival analysis. On median follow-up of around 73.3 months, that means on approximately 5 years on median follow-up, when we are using the palbociclib as a second line therapy, the median overall survival is around 34 months. And if you see the median OS in this placebo arm, it is around 28 months. So almost the overall survival is almost double in palbociclib plus fulvestrant arm after 5-year follow-up period. The overall survival in this study trials has also shown that the overall survival is also depend upon the sensitivity to prior endocrine therapy. So in those patients who are sensitive to prior endocrine therapy, there was seen that absolute improvement in median overall survival in palbociclib arm versus the placebo arm was around 10 months. So those patients who have previously responded well with the endocrine therapy, it is chance that they respond well with this palbociclib. This is the updated PFS in Paloma 3 trials. The median PFS was around 11 months versus 4.6 months in placebo arm. So the median PFS is also almost 3 times higher in palbociclib plus fulvestrant arm versus placebo plus fulvestrant arm. On subgroup analysis on the basis of menopausal status in Paloma 3 trials, on subgroup analysis in whether the patient is premenopausal, perimenopausal, or postmenopausal, the median PFS is almost same. It is 9.5 months in premenopausal patients versus 9.9 months in postmenopausal patients. And similar in the placebo arm also, the data is 5.6 months and 3.9 months. So there is no much difference in the efficacy whether the patient is premenopausal or postmenopausal. So conclusion of this Paloma 3 trials, the palbociclib when combined with fulvestrant, it significantly improved the median PFS compared with the placebo plus fulvestrant as a therapy in those patients who are HR positive and HER2 negative advanced breast cancers. A median PFS of around 11.2 months seen with the palbociclib plus fulvestrant compared to the placebo arm, where the median PFS is around 4.6 months. The palbociclib was well tolerated with most common adverse effect being neutropenia and leukopenia, what we have seen in the Paloma 2 trial also. And palbociclib in combination with fulvestrant is an effective treatment option those women whose cancer has progressed on prior endocrine therapy. The absolute difference in the PFS gain is around 6.6 months with the palbociclib plus fulvestrant, which was maintained for the overall survival. A 10-month improvement in overall survival was also observed in those patients who has shown the prior sensitivity to endocrine therapy. Safety data of the CDK4/6 inhibitors. We know that there are 3 CDK4/6 inhibitors, the palbociclib, ribociclib, and abemaciclib. And the most common adverse effects which is seen with the palbociclib is mainly hematological toxicity. There's the neutropenia, leukopenia, sometimes thrombocytopenia is seen. With ribociclib, apart from the hematological toxicity, there is the chance of the QT prolongations. So we have to do ECG on the regular basis. The chances of hepatotoxicity and GI disturbance is also there. In abemaciclib, apart from this hematological toxicity, the GI disturbance is the most important, along with the hepatotoxicity. And one unique adverse effect which is seen with the abemaciclib, which is not seen in the other CDK4/6 inhibitor, is the chances of venous thromboembolism. So this is the comparative toxicity of this CDK4/6 inhibitor. Although the chances of grade 4 toxicity is not seen or rarely seen in any patients, but the chances of grade 3 hematological toxicity is seen in the palbociclib, ribociclib, as well as the abemaciclib also. The hematological toxicity is least seen in abemaciclib. It's mostly seen in the palbociclib and ribociclib. But the GI toxicity, if you see the GI toxicity, is maximally seen in the abemaciclib. It is not seen in the palbociclib and very less in ribociclib. Similarly, the derangement of the liver function test is also more common in ribociclib and abemaciclib in compared with the palbociclib. So if you analyze all the adverse effect profile, the palbociclib is the most well tolerable drug among all these CDK4/6 inhibitors.
Sorry for interrupting. You have 4 minutes left to conclude.
Sorry?
You have 4 minutes left to conclude.
Okay. So monitoring, what we done in palbociclib, usually we do with CBC, because the hematological toxicity is the only toxicity seen with the palbociclib. Whereas in ribociclib, we have to do the CBC testing along with the ECG testing, electrolytes profiling, as well as the liver function test also we have to do. Again, with the abemaciclib, apart from the hematological profile, we have to check regularly this electrolyte profile as well as the liver function test also. So safety data of the palbociclibs. If you see the safety data, if the patients has developed grade 3 or sometimes grade 4 hematological toxicity, so we can have options of reducing the dose from 125 milligram to 100 milligram, and then the second dose reductions to 75 milligram. And if you see the landmark analysis at 3, 6, and 9 months, there is no much difference in the PFS was seen, whether the patient is taking 125 milligram or 100 milligram or 75 milligram. So similarly, there was no difference in seen whether in PFS as well as the overall survival. So if the patient is not tolerating palbociclib, we can reduce the dose. It will not affect the progression-free survival or overall survival. Now, what are the real-world evidence of these CDK4/6 inhibitors? These are the systemic literature review of the real-world evidence, and they have chosen certain parameters. The effectiveness of drugs, the treatment pattern, the safety profiles. They have taken economic outcome, the quality of life index, and the chances of the QT risk prolongation. And if you see this pie chart, the most the economical and the most tolerable drug, if you see, the palbociclib has the better edge if you compare with the other two CDK4/6 inhibitors. Now, what are the real-world evidence of the palbociclibs? This is the Flateron data. I'm not going to detail about the Flateron network. What this Flateron data says, the real-world PFS. According to this Flateron evidence, the real-world evidence, they have taken two parameters. The one is this stabilized inverse probability treatment weighing, and second is the PSM, that is the propensity score matching. And on this basis, they have seen this the real-world median real-world PFS as well as the overall survival. So according to this data, the this median PFS in palbociclib arm is around 20 months, where in placebo arm it is around 11.9 months. And in PSM profile, the palbociclib, so again the median PFS in real world is around 20.2 months versus 11.9 months in placebo arm. Similarly, this overall survival data, again, the overall survival is still not reached in palbociclib arm, whereas the median overall survival in letrozole only arm is only 43.1 months. So in conclusion, in the real world settings, the first line palbociclib plus letrozole is more effective than letrozole alone in a heterogeneous population and among the various patient subgroup. Although the median OS was reached in the letrozole alone group, the significant censoring in the OS analysis highlights the need for subsequent evaluation and longer follow-up is required. And these data complement the superior clinical efficacy observed when the CDK4/6 inhibitors were randomized in the clinical trials. The another real-world data, I'm not going detail of this study background. And if you see this real-world best tumor response, those patients who are treated in the first line setting with the palbociclib plus letrozole, they are associated with increased likelihood of tumor response compared to those patients who are taken treated with the letrozole alone. A generally consistent benefit of palbociclib plus letrozole versus letrozole alone was seen across all the subgroup of patients, whether the patient is having visceral disease or only bone metastasis, with no significant interactions demonstrated in any of the subgroup evaluated. The overall survival among the patients with one or more tumor response assessment. Among those patients with one or more tumor response assessment, the treatment with the palbociclib plus letrozole was associated with a significant longer median real-world overall survival compared to the letrozole alone. Among those patients with one or more tumor response assessment, treatment with the palbociclib plus letrozole was associated with a significant longer median real-world progression-free survival versus the letrozole alone. So in conclusion, so finding from these studies, the complement the data from the randomized clinical study, those show the significant efficacy of palbociclib plus letrozole versus letrozole alone. The another study was the IRIS study. And what this study, it was a retrospective medical chart review study, which analyzed the palbociclib as a first-line endocrine therapy in HR positive, HER2 negative breast cancer patients. And if you see the result of this, the IRIS study, the PFS and OS, if you see at 12 month and 24 month in across all the globe, so with the US, Europe, Canada, Argentina, the PFS and OS rate is almost similar in all subgroup of patients and all ethnic group of patients. So the conclusion of this IRIS study is said that the PFS and OS rate in the patient treated with the palbociclib as initial endocrine therapy at 12 months was more than 82%, and it was more than 95% respectively across all the region. The PFS and OS rate in the patients treated with the palbociclib plus fulvestrant at 12 months was more than 80% and more than 95% respectively across all the region. Medline study, I'm skipping this study. It's the same things what they are saying. Treatment, the treatment satisfaction survey. What treatment satisfaction survey of the palbociclib in real world evidence says? The real world evidence says that the 92.2% the patients reported that the side effects were as expected or even better than expected. Most patients across all the 6 countries felt that their treatment would help them to return to their normal life, and nearly all patients felt that the medication benefit had met or exceed their expectation. The Indian data, the data was published by the RGCI New Delhi of palbociclib, use of palbociclib, and the result of this data says that the median PFS is around 20.2 months. When it is used as the second line, the median PFS is around 12 months. The overall response rate was 80% when the palbociclib is used as a first line, and when it is used as a second line, the median PFS is around 40. This overall response rate was around 48%. The toxicity, 10% of patients had grade 3-4 adverse events, and 20% of patients had neutropenia grade 3-4, while no patients had developed any febrile neutropenia. So the conclusion of that study says that the present real-world data of palbociclib used in Indian population suggests the similar effectiveness to previously published real-world evidence, and it is the standard of care as a first-line first-line therapy in metastatic breast cancer who are HR positive and HER2 negative, and also as a second-line therapy. So this is the another data from Indian institutes, that is the Cancer Institute Chennai, and these data also say, if you see the median follow-up of 13-month periods, the median PFS when it is used as a first line, the median PFS is around 18 months. The median overall survival has not reached. 1 year PFS is around 73.3 months, and 1 year overall survival is around 90%. So in conclusions, complete response was seen in 4 patients, and none of them has progressed at the time of the follow-up. 24% of patients required dose reductions due to the fatigue and mucositis. However, none of them required drug discontinuation. Had an unusual number of patients with the brain mets who achieve a complete metabolic remission with the letrozole plus palbociclib, and the median PFS in this study was 18 months if you compare with the PALOMA-2 trial, where it was around 25 months. So this reflects that the fact that the real world outcome is usually inferior to the reported in the clinical trials. So the reason could be due to the inclusion of all these all-comers, decreased compliance with the drug intake, and the shorter follow-up. So these saw that how the data differs when we compared with the trial data and the real world data. So now I'm going to conclude the session. So had palbociclib changed the treatment paradigm? Yes, the changing treatment paradigms prior to early 2015, there was no new treatment options for the advanced or metastatic breast cancer patients has been introduced since aromatase inhibitor for over a decade. Little was known about the patient's experience and the satisfaction with CDK4/6 combination treatment at the post-approval in real-world setting. When this palbociclib was approved, so many clinicians like us also hesitate to start with the treatment because we don't know how the patient will respond. So what does the data tell us? The data tell us that the palbociclib plus letrozole in the first-line metastatic breast cancer has shown a median PFS of over 2 years. The real-world data complement the superior clinical efficacy observed in randomized clinical trial and support the use of palbociclib in combination with aromatase inhibitor as a standard of care in the first-line setting, or along with the fulvestrant as in the second-line therapy. Quality of life is maintained even with the longer treatment duration, with high patient treatment satisfaction score with both palbociclib combination, whether it is with aromatase inhibitor or with the fulvestrant. Thank you.
Thank you, Srikant sir, for the wonderful talk. The next session that we have is actually almost linked to the talk that you have already given.